Welcome to fourth lecture in the series. In this video, you will learn about nodular patterns of disease. Let's go over the definition of a nodule. Nodule is a rounded or regular opacity, well or poorly defined, that measures less than 3 cm in diameter. In contrast, a micronodule is a focal round opacity less than or equal to 3 mm in diameter. This is a diagram comparing the 3 different patterns of nodules. They are centrilobular, perilymphatic, or random, depending on the anatomic distribution of the nodules. With regards to the secondary lobule, the centrilobular pattern can then be broken down into tree in bud pattern or poorly defined nodules. Let's start by discussing centrilobular nodules. Centrilobular nodules can be divided into tree in bud or poorly defined nodules. These are 2 patterns of nodules clustered along the centrilobular structures, sparing fissure, and interlobular septa. The tree and bud pattern is most commonly caused by impacted bronchioles and alveoli, and are thought to resemble the branches and buds of a tree, as shown in this photo. Tree and bud pattern is most commonly seen in infectious bronchiolitis due to endobronchial spread of infection, endobronchial spread of TB, of bronchopulmonary pneumonia, mucus plugging in bronchiectasis or cystic fibrosis, or less often in aspiration. This pattern can also be seen with endovascular metastases and excipient lung. This is a typical example of tree in bud pattern in a patient who had sputum positive for TB. This is an example of diffused bronchiolitis showing tree in bud pattern. The image on the left is a MIP, which stands for maximal intensity projection, and makes the vessels appear like tubular structures, and allows you to differentiate nodules from vessels. Using the MIP can be a very helpful way to find nodules and see their pattern. The image on the right is a single thin section. The thin section image also shows bronchial wall thickening and some bronchiectasis, which tells you that this is an airway disease rather than a vascular disease. Airway causes of tree and bud pattern are much more common than vascular causes. This is an example of tree and bud pattern in a patient with squamous cell carcinoma leading to endovascular metastases in the lung. As you can see, these nodules have a range of sizes. Some are small, medium, and some are large. The heterogeneity of the nodule size should make you think of metastases also. Sometimes infection or sarcoid can result in heterogeneity of nodule size. An important point to remember is that when we think of tree in bud, we normally think of airway disease. You can look for bronchiectasis to try to clarify if this is due to airway or vascular disease. If bronchiectasis or bronchial wall thickening is present, the tree and bud pattern may be attributed to airway disease. If not, both airway and vascular disease must be considered. Now let's discuss poorly defined centrilobular nodules. These usually occur as ground glass nodules within the center of the secondary lobule without associated branching. This pattern is usually associated with airway disease such as hypersensitivity, pneumonitis, and respiratory bronchiolitis. Because the centrilobular arteriole follows the course of the bronchiole, this pattern can also be associated with small vessel diseases such as vasculitis, endovascular metastases, excipient lung disease, and pulmonary capillary hemangiomatosis. As discussed before, look for airway disease meaning bronchiectasis, mucus plugs, and wall thickening, as these point to transbronchial rather than hematogenous spread as compared to perilymphatic and random nodules, which we will discuss later in this video. Centrilobular nodules spare the septa and pleural surfaces. As compared to tree in bud, poorly defined centrilobular nodule are more fuzzy, meaning ground glass, and are not associated with branching. This is an example of poorly defined centrilobular nodules in a patient with respiratory bronchiolitis. Note the upper lobe, predominance of respiratory bronchiolitis. There are also some nodules along the fissure, but the predominant pattern here is centrilobular, so we will stick to the predominant pattern. This is an example of a MIP image on the left from a patient with a disease process associated with centrilobular nodule, compared to a thin-cut image from a patient with a disease process associated with paralymphatic nodule. Centrilobular nodule typically spare the subpleural space, leaving a few millimeters uninvolved around the edge of the lung, which we can see in the MIP image. These nodule, signaled by the red arrows, are distinguished from perilymphatic nodule, which are centered on the septa, pleural surface, or bronchiovascular bundles. Let's move on to perilymphatic nodule. As you may remember, there are lymphatics in the interlobular septa and along the bronchiovascular bundles of the secondary lobule. The lymphatic channels are seen here in green. Therefore, if nodules are located on the bronchiovascular bundles and on the interlobular septa and fissure, they have a perilymphatic distribution. This pattern is associated with sarcoidosis, pneumoconiosis like silicosis, and lymphangitic carcinomatosis. Because these nodules can occur within the interlobular septa, there is an overlap in the differential diagnosis of perilymphatic nodule and the differential diagnosis of the nodular reticular pattern. In fact, you may hear pulmonologists and radiologists comment that if a CT looks like sarcoid, then it could also be silicosis. For perilymphatic nodule, note the location of the nodule centered on the fissure, interlobular septa, and on the visceral pleural surfaces. Some of them will occur within the secondary lobule as they contract along the bronchiovascular bundle. This is an example of perilymphatic nodule in a patient with classic simple silicosis. Note the location of the nodules on the fissure and on subpleural space and pleura. These nodules actually sit on and touch the fissure. There are also nodules in the parenchyma. If you could zoom in, these nodules would be on the septa or along the bronchiovascular bundles. Silicosis also has a predominantly upper lobe distribution. This is an example of perilymphatic nodule in sarcoid. There are nodules following along the bronchiovascular bundles on the left. Within the red circle, there are also nodules on the fissure. Normal fissures should be almost imperceptible and smooth. These fissures are irregularly thickened, which suggests nodularity within the space. Now let's discuss random nodules. Random nodules have features of both centrilobular and perilymphatic. As compared to centrilobular nodules, random nodules don't spare the septa or pleural surfaces, whereas centrilobular nodules do. As compared to perilymphatic nodules, random nodules are more diffusely distributed. Random nodules can be found associated with the septa, pleural surfaces or bronchiovascular bundle, as well as elsewhere in the parenchyma. The random nodular pattern is associated with hematogenous spread of metastases, miliary tuberculosis, and miliary granulomatous fungal infections. Note the nodule on the pleural surface and interlobular septa hematogenously spread. Nodules end up everywhere and randomly distributed because there are capillaries everywhere, and the particles that cause disease lodge when they get too big to pass through the blood vessels they are in. This is an example of random nodule in a patient with metastatic thyroid cancer. The image on the left is a MIP. Note the nodules on the pleural surface and also diffusely throughout the parenchyma. This is a good example of how these disease processes are in a continuum. This looks like centrilobular in some areas, but I suggest you focus on what the predominant distribution is, which in this case is random. There are nodules in the parenchyma, along the fissures, and in the subpleural lung. Let's review by putting together what we have learned into an approach for nodular disease. When you find a predominantly nodular pattern in a chest CT, ask yourself, are the nodules associated with pleural surfaces or septa? If the answer is yes, then you are dealing with perilymphatic or random nodules. Perilymphatic nodules are found on the bronchiovascular bundles, as well as the pleura, and they are usually caused by diseases such as sarcoid, pneumoconiosis, and lymphangitic carcinomatosis. On the other hand, random nodules, besides being associated with the pleural surfaces and septa, are also found randomly distributed within the lung parenchyma. In this case, think of miliary tuberculosis, miliary fungus, and metastasis. If there are no nodules along the pleura or the septa, the nodules are centrilobular. Look for tree and bud pattern. If there is tree and bud pattern, then this is most likely infectious or inflammatory airway disease. If there is no branching associated with the centrilobular nodules, then this is likely due to hypersensitivity pneumonitis, RBILD, or pulmonary capillary hemangiomatosis.